Good afternoon, everyone. Welcome to today's webinar, Beyond the Image, a paradigm shift in clinical workflow with 3D fusion and augmented reality. I'm Leslie Samay, Director of Professional Development at Great Valley Publishing, publishers of Radiology Today magazine, and I'm your host for today's show. Radiology Today magazine is happy to collaborate with MediView on this webinar, a Cleveland, Ohio-based med tech company working to advance human health through its digital augmented reality ecosystem. MediView's intuitive augmented reality visualization platform aims to unlock the full potential of 3D data to transform image-guided medical procedures with intuitive 3D X-ray vision visualization, seamless remote collaboration, and evidence-based data insights. I'm also honored to introduce today's presenter, Dr. Bradley Pua. Dr. Pua is a nationally recognized leader in interventional radiology, known for advancing multidisciplinary care, early cancer detection, and procedural innovations. He earned his BS in chemistry from New York University and completed his medical degree at NYU School of Medicine. After 3 years of surgical residency at NYU Medical Center, Dr. Pua trained in interventional radiology through a fellowship at NewYork-Presbyterian, Weill Cornell, and Memorial Sloan Kettering Cancer Center. He completed his diagnostic radiology residency at Cornell, serving as chief resident. A champion of emerging technology, Dr. Pua integrates augmented reality solutions into procedural planning and image-guided interventions. His work explores how augmented reality overlays can enhance precision, safety, and outcomes across interventional oncology and complex vascular treatments. And so with that, I'm pleased to welcome you today, Dr. Pua, and I'm going to turn it over to you to take things away.
Great. Thank you so much, Leslie. That was really a very generous introduction. Really excited to be here today to really share something I'm very passionate about. I think in radiology, and I've been in radiology for quite some time, I think more and more we're seeing that we're trying to rely upon our mental reconstruction of two-dimensional images that we acquire all the time, right? Our CTs, our MRs, our ultrasounds. But increasingly, I think that's creating a mental load on us to try to reconstruct these in 3 dimensions so that we can actually utilize them day to day. And so hopefully through this discussion that we have here today, it really hopefully it empowers everyone here listening to actually do more to try to incorporate some of this technology into their current workflow, as well as think more about how you can contribute to advancing these technologies for us. And certainly, I think one of the other exciting things that I'm going to be talking about today is not just about 3-dimensional renderings, but how we can now leverage 3-dimensional renderings in this new up-and-coming display modality, augmented reality, and how the fusion of both of them will really help our practice moving forward. So again, very excited. So before I turn to talking about how to utilize it, I think this is really good to provide some background for all of us, right? I think what's fascinating to me is thinking a little bit about how traditional surgery has changed and how procedural areas such as interventional radiology, gastroenterology, endoscopy has actually evolved at the same time. So if we think about like decades ago, surgery, traditional surgery, as I like to call it, is you made larger incisions and the surgeon looked directly at a patient. You looked at the incision, you looked through and opened up the patient and looked at the disease organ, and oftentimes remove it or do something to actually treat it. The treatment is often utilizing these short tools or your hands. Now, as you can imagine, when we started to actually evolve and make smaller incisions to better patient care, what we ended up doing was by making those small incisions, we couldn't look directly at the patient anymore. We needed something in between us, right? We used cameras. Either we looked directly through a scope or we put a high definition camera on the back of the scope. And now the surgeon is often not looking at the patient, but looking somewhere else, looking at a display monitor. And the tools or the way you interact with patients are longer tools, laparoscopic instruments, video-assisted thoracoscopy instruments. At the same time, along the vein of making smaller incisions, we actually started thinking about, well, perhaps we shouldn't be making incisions at all. Perhaps we should actually be going through natural orifices or natural orifice surgery. So our endoscopists do a great job of this, going, say, through the throat with cameras to actually perform traditional surgeries through these natural orifices, where the incision is actually on the inside. What's common here between laparoscopic surgery, video-assisted surgery, and natural orifice surgery and endoscopies, bronchoscopies is the fact that we're still, yes, looking at a display somewhere else in your operating room or your procedure suite, and interacting with the patient through a long tool. Now, interventional radiology is, I'm an interventional radiologist, but interventional radiology, as it evolved with its parent, right? Radiology. I think the vast majority of this audience here is probably from a radiology background, but we're very used to acquiring images, the CTs, the MRs, the ultrasounds. But interventional radiologists utilize these images as our visualization tool to perform procedures, right? So, what's fascinating is that as an interventional radiologist, you're still looking at a display monitor. And so, what does that mean in terms of this shift? It's certainly great for patient care, great for cost effectiveness because we lower hospital length of stay, but it actually creates a cognitive load on many of the providers because all of a sudden you're interacting with multiple different technologies, multiple different displays. So that's where I want to shift then to even more background. Well, what is this concept of cognitive load? So cognitive load refers to the mental effort required to perform our complex tasks. When these demands exceed the capacity of our working memory, an overload occurs. This has been shown in multiple studies leading to errors and also hindering further learning and really adaptation or our ability to actually quickly adapt to changes in a interprocedural setting. Um, there's three different types of cognitive load. The first is intrinsic load, and this relates to the inherent complexity of a task. For a surgeon, it may mean your hands-on skills and your spatial awareness. For an interventional radiologist, it may mean the ability to interpret images quickly and utilizing the appropriate devices. Then there's extraneous load. Extraneous load is specifically defined as irrelevant or non-essential information that adds mental strain. However, really, some examples really are things like managing patient vitals, dealing with interruptions, or troubleshooting equipment. Now, arguably speaking, this is not non-essential, right? But what it means is that it's non-essential for the specific proceduralist or the surgeon. It could very well be something delegated to somebody else in the room or the procedure team. Then there's germane load, and this is kind of very loaded here as well. And it's really our mental effort associated with learning and training. It includes teaching trainees. It also includes learning from the procedure itself. So you can imagine that if there's an ability to actually record in real time what you're doing for review afterwards, that becomes really powerful in actually your post-procedure review. So there's certainly a growing interest in understanding and minimizing this cognitive load in procedural environments, and therefore reducing this unnecessary burden will certainly be very impactful in improving patient outcomes and procedural efficiency. So now that we've talked about what the cognitive load is intraprocedurally, if we step back even further, the cognitive load for treating a patient from a surgeon's and procedural standpoint is even beyond just the intraprocedural area, right? It is actually through the pre-procedure area, intraprocedural, and then the post-procedure setting, and then learning from that post-procedure interaction, the outcomes, or your germane load, as we're looking at it from a cognitive load perspective. So thanks to AI, we created a workflow of what my typical workflow would be, right? I get a referral from a patient with a specific chief complaint. Now, often during this entire interaction with the patient, I'm documenting what the chief complaint is, what the medical comorbidities are. And then as I learn more about the patient, I start interacting with the patient through a review of images. Explaining to a patient through shared decision exactly what the disease entity is, what we're going to treat, and how we're going to treat it, or formalizing a specific procedural plan. Now, this is where we need to do a lot more work, right? In terms of how do we now annotate these procedure plans? Many of us may annotate directly on the images. You write little notes to yourself on the DICOM images and you save them in your picture archiving system. Many people write little notes to yourself. Maybe you'll write a little note that you understand in the electronic medical record. However, with all these notes, though, how do you then actually review these notes or take these notes into the procedure room when you need to make fast-paced decisions? And that's really where, and we'll get into this, augmented reality becomes remarkably useful as a tool to help you. If you think a little bit about what the different strategies are people take, sometimes you will review your notes right before a procedure. Sometimes, if you're fancy, you will even have a big, large monitor actually situated somewhere in your room that you'll pull up images, right? Or pull up your notes. But that's not commonplace. So we need to do a little bit better job in terms of getting us there. So I introduced one of the concepts that we want to talk about today outside of 3D segmentation and 3D renderings, which is augmented reality. So, I think it's important for me to really define what augmented reality is, right? And really, augmented reality refers to the overlay of digital information, such as 3D anatomic images, procedural guidance on your real world or in real time. It really falls in the spectrum of mixed reality or medical mixed reality. And the spectrum spans the real environment all the way to virtual reality. Real environment, we know very well, right? The corollary from earlier is real environment is traditional surgery. You're interacting directly with your environment with your hands. Augmented reality is a little bit more closer to what you have with your heads-up display in your car, right? You have a system where your digital overlay projects onto the real world, often through visors or headsets. Then there's augmented virtuality. Augmented virtuality is where you have a immersive virtual environment. However, your real environment is actually collected from cameras throughout, say, your headset. And a good example of this now is the Vision Pro, where you actually have cameras interpolating what that reality is and merging it into the digital reality. Then there's something that the gaming world is very familiar with, right? Virtual reality. It's really a fully immersive digital environment where the real world is not visible at all. And so how does AR then play a part? This is a very busy slide, a little bit with some intention. Because this field being so up and coming, there's a lot of different places AR can play a role. However, I try to choose areas where I think are the lowest hanging fruit for all of us to actually engage in, to actually make a big impact very quickly. The first is interpretation of complex anatomy from 2D imaging. As I discussed earlier, we're inundated with two-dimensional imaging. Every patient has some form of a CT, MR, or something else that we're now trying to interpret in our minds in 3 dimensions. I have frequent AVM patients where there's multiple complex feeding vessels, and I'm trying to figure out by scrolling through the axial, sagittal, and coronal images exactly where these feeding vessels are. However, one can imagine if you could do a 3D segmentation, even interacting on the desktop, remarkably powerful to be able to actually figure out exactly where the different feeding vessels are, even vital structures. You can imagine that if you actually put this on a VR headset or an AR headset, this becomes even more powerful because you are now interacting more naturally with your environment, right? More naturally with this 3-dimensional object in your field of view. Ergonomics is a huge thing in medicine. I spent some time on that slide about how we talked about laparoscopic surgery and natural orifice surgery and where surgeons and proceduralists are now looking in a different direction, right? Well, oftentimes if you actually look at how most contemporary proceduralists and surgeons work now, they're actually not looking at the patient. You're often cranking your neck, doing something else, right? So This is often referred to in the field as screen to field shifts. So just oftentimes a lot of movement of your head and neck, looking at different inputs. And so we want to try to reduce that. And AR is a great place to reduce that because you'll be able to now actually have everything in your visor, in your field of view, anywhere you want. Then there's how do we reduce high pressure decision making? And decision making is really a matter of if you're presented with something that you're not expecting during a procedure or a surgery, and you need to make fast decisions. Well, what are those fast decisions based upon? The fast decisions are based upon either what your recall is, what the notes are you reviewed, your experience, but one thing that could be of significant added value is if you're able to actually pull up references right then and there, pull up what variant anatomy could be, pull up patient images, pull up your notes, pull up what's in the electronic medical record to really help you make a quick, informed decision during these high pressure situations. Then there's the ability to multitask, being able to control multiple devices at once. Certainly also being able to look at various displays, such as your vitals, and also really to call for help. Calling for help has new meaning with an augmented reality headset because you can actually call in someone with, hey, what we're on now, a Zoom or Teams meeting, for instance, um, and have them actually interact with you in real time in your space, seeing what you're seeing. Um, and we talked a little bit about germane load a little earlier in terms of how do we build in time to actually reflect on the outcomes. What did I do right? What did I do wrong? What instrument could I have used better? Where we are today when we actually have that time to reflect is really after the procedure where we're actually putting together our procedure dictations, right? However, our dictations and our communication to the rest of the medical community and the patient is actually becoming more and more refined and streamlined, a lot of which is driven by billing, right? There's certain keywords that we'd like to say, but at the same time, when we actually now, as a proceduralist, go and reflect back on what we did, it's really hard to decipher those key words because it actually be a lot more useful for us in natural language. An extension of that would be, well, what if I videotape my entire procedure and I was able to actually review it? Or there's some form of a algorithm that I can layer upon it to tell me, well, these are the key things that are related to better outcomes. So I think that this is sort of the future of where we can leverage augmented reality and not certainly outside of the scope of what I'd like to talk about today, but certainly a concept I'd like to bring up as something that's really exciting and evolving. So I spent a lot of time talking about the intra-procedure, so the middle. How can AR or 3D segmentations in procedures be helpful in the pre-procedure setting? Well, certainly the ability to have 3D renderings and complex anatomy, the ability to actually interact with it and look at it, remarkably powerful to actually even fuse different images. And I'll talk a little bit about that. In the post-procedure setting, we talked about that as well in terms of being able to review and also even creating a training library for your residents or providers who might not necessarily do that specific niche procedure or may not have a catchment of certain very rare disease entities that you are interacting with. Education. Education remarkably important, right? And in multiple different ways, not just education for the next generation of providers, but also patient education. You can imagine an AR or VR world where you're educating and showing a patient exactly what they potentially could experience, really teaching individuals how to make an informed decision about their disease, and nothing more powerful than to be able to actually take a 3D rendering of their anatomy, interact with it. Frankly, just speaking personally, half my practice is pediatric, and I find it really gratifying for not only myself, but our children and also family members to actually interact and understand what the specific entity is as we kind of then discuss what the treatments and what the expected outcomes are and what the future relationship is like. We talked a lot about 3D anatomy characterization, so I will skip a little over this. Really, the delineation of this is really more for your reading in the future. And then there's that remote collaboration piece. And the remote collaboration piece, I can't highlight more, right? You can imagine, I work at an academic center. You can imagine where I'm traditionally now as an IR, when I'm teaching, often I'm in the control room, and what can I see? I can see the fluoroscopic image of what my resident is doing. Um, and however, I don't necessarily see their hands. So you can imagine a world where if the trainee has an augmented reality headset on, I can see both their hands and also what's happening on screen, or what the result of what their hands are doing in the patient, or fluoroscopically, or via CT. And so the education is a lot more specific in terms of, well, maybe you should use your index finger, maybe you should twist your hands in a certain way. And you can also imagine a world where different providers within the same practice can help one another. Oftentimes, when I'm on call in the middle of the night, I'd love to call somebody in the middle of the night and ask their opinion. Well, when I make those phone calls, the best I can do often is just describe what I'm seeing, right? But a picture is worth 1,000 words. But if you supercharge that with having an augmented reality headset where somebody can log in, see what you're seeing in real time, and even be able to annotate in your three-dimensional space, that is remarkably powerful. And I think that also is beyond how much experience a person can have. Oftentimes, despite the amount of experience, you often get so hyper-focused in what you're doing, having multiple sets of eyes looking at it, giving you different opinions, really leads to better patient care and outcomes. Then there's the remote assist, the true remote assist. Somebody where in a rural setting or in a international setting, where there's maybe a specific entity they're not used to, or a specific device they're not used to using. Well, it'd be very easy to call one of your colleagues and say, well, how can you help? Please explain to me, how I could be utilizing this instrument more effectively, and how can I be treating this patient more effectively. So I touched upon this earlier, but I want to give you an example of how powerful it is to actually fuse images together even prior to getting to 3D segmentation. We have most patients now, especially oncologic patients, have multiple modalities, right? Many people have CT scans. Then we get PET CTs to look for areas that are particularly avid, not only to guide biopsy for diagnosis, but to guide treatment. Well, maybe there's a certain area that I need to retreat because it's still PET avid. Then there's specific modalities that are keyed in and better at identifying certain pieces of anatomy, such as if I want to see a nerve, MRI is often a great modality to see specific nerves or things I want to avoid. Right. So in this is a very simple example of a patient. I use this sort of fusion technology and also co-registration of the 3D segmented technology with augmented reality to help me. This was a biopsy procedure where a patient was undergoing treatment for a certain disease where there were multiple abnormal lymph nodes in the groin here. If you looked at it with ultrasound, you'd see that, hey, structurally speaking, with ultrasound, all the lymph nodes look abnormal. However, when this patient got a PET scan, there was only one area that was still avid. So the ask here was, well, could you biopsy that to see whether or not there's viable tissue, whether or not there was a mutation that we can act upon to actually help streamline and guide therapy. So what did we do in this case? I actually took a PET scan and I took a CT scan. We took a cone beam CT to compensate for any temporal changes, not only from the PET scan itself, but from the position of the patient. and we did a 3D segmentation. We layered that upon a real-time ultrasound to compensate for the lack of the real-time effect of these static modalities such as CT and MR and PET scan to allow me to then say, all right, I see all these abnormal lymph nodes on ultrasound, but now I annotated that, hey, this lavender area, and hopefully this projects well, is the target lymph node that's viable on PET. This is what I want to see. And oftentimes, yes, our current standard is I'll do it by anatomy. I'll go back and forth and pull up on another display my PET scan just to ensure that's the right one. But you can imagine how powerful it is then to actually have all of that fused in one, annotated, so that to reduce that cognitive load, reduce the ergonomic field to screen shifts. Pre-procedure planning. This is just an example of a patient of mine with a large AVM in the pelvis. Well, one of the asks was, I knew this was coming off the internal iliac artery, but well, how many branches are there coming off? How many areas do I need to look? It's not to say that I couldn't have made these decisions during an angiography and being prepared, but it's always nice to actually understand, well, what are the different vessels? If I close this one, what other ones are open? And you can imagine it being powerful, number one, just to even interact with it on a desktop or on your device, such as your tablet. Or, and I'm a very, I'm a type of person that likes to use my hands, to actually get yourself in a VR environment or an AR environment, just as in this example here, where I actually with my hand, with some hand gestures, actually manipulate this and walk around this specific anatomy. This is another example of how you can utilize this to decrease your cognitive load intraprocedurally. This is a patient of mine where had intercostal pain that was refractory, or I wouldn't say refractory, but had some minor improvement to nerve blocks and even an alcohol neurolysis. But there was actually something anatomic I needed to treat. And so, what is our current standard? You can do this under fluoroscopy, right? Where you put a little needle in, you inject contrast to show that you're actually filling the intercostal, the space underneath, the neurovascular bundle underneath the ribs. Or you can use ultrasound and you count and recount the different spaces to ensure you're actually targeting this specific rib level that you're interested in, right? But that adds time, that adds the potential for error, especially in someone with a lot of soft tissue, right? You may mark an area with your surgical marker, but the soft tissue shifts and compression with the ultrasound may actually move that target. So you end up often counting and recounting again. This is an example of how you can obviate that, where if you did a co-registration of the patient anatomy, what we did here was we rendered the ribs, and in that sort of characteristic lavender that I like to use for my targets, this state to me, this is the level that you're interested in. This actually afforded me the ability now to actually come from several intercostal spaces below and actually target it with some comfort that I'm in the right place. And I did this from several intercostal spaces because I wasn't doing a nerve block here, but I was doing a cryoablation of that area. Some other examples of how this fusion technology of 2D to 3D and then to augmented reality and merger and co-registration on the patient is helpful. These are some examples of targeted lesional biopsies. One on the left-hand panel here is a targeted liver biopsy. On the right-hand panel here is a targeted renal biopsy. I think we've all been there in that sometimes you do an ultrasound, you think you see an abnormality, you're not really sure. You're often left with, well, here's the portal vein branch that I see on the cross-sectional imaging. I'm going to try to correlate it. I think I'm comfortable. I want to give perhaps a contrast-enhanced ultrasound to make me a little bit more comfortable. Wouldn't it be nice to have some overlay? And certainly there's a lot of other overlay technologies out there, but this is an example of how augmented reality overlay with your 3D segmentations can be remarkably helpful, right? Hopefully this projects for you, but an overlay of the liver itself. You see the ribs and also the target lesion I was going after. Remarkably also helpful in the kidney biopsies, where oftentimes the renal parenchyma is such, especially in the lower and upper poles, where it's actually hard to find the lesion sometimes. And being able to be confident that the lesion you saw on say, enhanced cross-sectional imaging is what you're actually interested in biopsying or treating. Another example of how this can become powerful, and this is a simple example, admittedly, is really avoiding critical structures. We now, have shown an example of how this technology can be utilized to target specific areas, but how can you use it to actually avoid certain areas while you're targeting what you're interested in? This is a patient with a deep inguinal lymph node and overlying epigastric artery I was trying to avoid. So what did I do? We segmented out the bones just for landmarking. And the target, the lymph node of interest in this lavender, and the overlying epigastric artery in purple. And yes, admittedly, you could use a different lower depth probe to find all these structures and mark it out. But it's always nice to be able to just overlay that to give you that added comfort and make it a little easier. So as you can imagine, this is also not that far off. You start marrying it to some navigation tools, being able to actually help you navigate that and make you, again, a little bit more comfortable that you're doing something more accurately and effectively. We touched upon ergonomics a little earlier. This is a nice example of how even for procedures like a biliary drainage, where I'm trying to pass a needle into a dilated biliary duct, then putting a drain in to divert bile from a downstream obstruction. Oftentimes, these are done with two modalities, right? They're done with ultrasound and fluoroscopy with contrast injection. And oftentimes, these may not be actually on the same monitor, or if it's on your same monitor and you're lucky enough to have it on your same monitor, you're often still moving your head in different places because that, say, 55-inch monitor still takes up space in your field and you need to move around. Well, if you have this now on a headset, all of a sudden you can put this anywhere you want. And this video I'm showing you shows that even with some visual cues, you can actually move an ultrasound anywhere you want. And you can also see some fancy other things you can do, right? You can actually do a nice segmentation and float this anatomy above the patient, or if you needed to, after floating in and interacting with it, then register it directly on the patient. Um, and so it's really highly customizable in that way. I'm going to show you another example of, again, that same patient I was trying to do an intercostal cryoablation on, where with some audio cues, I can interact with the system to actually pull up different parts of anatomy. I'm saying show bone here. Yeah. Now I'm comfortable where I am. I can now hide the anatomy again to make it a little clearer as to what I'm doing. As I spent some time talking about a little earlier, this is an example of how remote collaboration could potentially work. This is something that I did with one of my technologists in the control room, where I am actually interacting with him on a Teams meeting. I can put this anywhere in my field of view, but what's remarkably powerful is the fact that he sees what I'm seeing in my visor. Yeah, he's probably as dizzy as I am moving my head around. But he's able to then annotate in my three-dimensional environment, put arrows in different places, actually advise me in different ways, and I can actually walk around this arrow in 3 dimensions. And we're only scratching the surface of this, right? You can also imagine a world where multiple people in the room are interacting with this same environment. Multiple people, not only in the room, but in a conference room across the hall or across the world, interacting with this. Really a lot we can do in terms of education and harnessing the different expertise from different providers. A little bit of a wordy slide, really meant for you to digest upon this after this. But so what are, I talked about the exciting stuff, right? Which is, what we where we're scratching the surface and where we're currently at with 2D to 3D segmentation, how we interact with 3D anatomies, and how we can leverage AR to really see 3D anatomy in a different world. And I like to bring us back to that, one of the original slides where, we departed as we move from traditional surgery to minimally invasive surgery, what we're looking at, how we're interacting with patients. We like to bring that back, right? We bring that back with this type of technology. We bring it back because now all of a sudden we can look at the patient again. We can look at the patient with all the information that we have at our disposal in different places in our field of view. So really remarkable. But certainly, what are some of the things that we all as a community need to do to overcome to see wider adoption and wider use of this type of technology? Well, certainly there's the technical and anatomic limitations, right? Most of our images are pre-procedure images done temporally in a different time than when the patient comes for their actual procedure or surgery. So how do we overcome this temporal difference? There's certainly a lot of co-registration tricks that we can do, but a lot to be done there. Then there's how do we compensate for respiratory motion? Cardiac gating? How do we compensate for things like tissue deformation? When you push down with your ultrasound probe, now all of a sudden, what you the all the planning that you did is now slightly a little different because of the deformation. Add to the complexity of what if it's a larger surgery where you're moving things out of the way? How do we compensate for that? So there's really a lot to be done in this field. It's a very fertile field for investigation and collaboration amongst the group. Um, in terms of what can we do as a group to actually further see this, really the call to action here, right? The call to action here is we all need to engage in these larger, more rigorous trials, not only to help see the end goal of seeing more wide adoption of AR, but to prove its efficacy and value, because ultimately, one of the other large barriers as well is really reimbursement, right? Reimbursement, how do we get people to adopt this into their workflow? As a provider, it's hard for me, even though I'm really engaged in technology, to want to adopt something that adds time or interrupts what I'm used to in my workflow. So we need to ensure that these types of technologies work really well in a proceduralist workflow, or has significant enough enhancements that it actually engages the proceduralist to change their workflow to adapt to this. Then there's that big elephant in the room, reimbursement, right? Reimbursement for augmented reality enabled procedures is emerging and evolving, admittedly. We do anticipate some new procedural and technology codes to be introduced in the future. However, we need to do a lot in terms of generating the evidence so that when these reimbursement codes come in, they're at favorable reimbursements, right? We need to really show what the value add is. Another wordy slide. Some of it a little repetitive, but it bears repeating. Just sort of the infrastructure and the cost barriers and the reimbursement barriers and the regulatory barriers we need to overcome. Certainly, while this technology is not as costly as, say, bringing in a new robot, bringing in a new angiography suite, there is still some cost to this. What I like about this technology is potentially as it develops, it is also a little bit democratizing in the sense that it's a relatively lower cost. It can be harnessed to wireless solutions where you can actually bring this anywhere you want. One can make the argument that it could be more widely acceptable, but because this is new technology, this is perceived as a cost now to a lot of institutions bringing this in. So we need to overcome that. There's a lot of this big IT infrastructure lift, right? Not only from a bandwidth perspective of interacting with within a lead line room or interacting in a space where there's a lot of devices, but also how do we ensure that all of a sudden the wireless exchange doesn't cut out? So a lot of these infrastructure changes and enhancements need to be added. Then there's interfaces with all the other data solutions that you already have in your institution. How do we pull up from the EMR? How do I pull up my notes in my curated way? How do I then interact with my picture archiving system? All these things have to be figured out. We talked a little bit about the infrastructure demands in terms of bandwidth already. And certainly, I'm not even going to touch upon the necessity for ensuring that all these areas, all these exchanges of information need to be encrypted and also in HIPAA compliant uh, data exchanges. But that is something that we need to address as well. All that said, it really allows us then to say we have the evidence, we've thought this out. We now go to these regulatory bodies, our institution, to advocate for widespread use of this because we've now demonstrated value. We now need the reimbursement codes. We now need to now get to the public to say this is ready for prime time. So some closing thoughts. We talked a little bit about how 3D segmentation and image fusion are really not just tools. To me, it really represents a new way of thinking. When I started utilizing this more and more, it all of a sudden changed the way I actually look at things available to me. Um, Really made me reflect on how do I actually better change my workflow in terms of the notes I'm taking, my pre-procedure planning, how I interact with the patient. Really, introduction of all of these new technologies into a proceduralist workflow is really changing my mindset, frankly, in terms of how I interact with patients, how I plan for procedures, how I do procedures, how I even do quality assurance on myself and my practice. So in the end, it's really all up to us to help validate and integrate these technologies into our workflows. And I hope that this talk really spurs your imagination as to what we can do. And really, again, is that call to action for all of us to really work together in this really exciting and emerging space. So with that, I thank you, and hopefully we have some time for questions.
Awesome. Thanks, Dr. Pua. That was amazing. We do have some questions. So let's jump in. The first one just popped in from Jonathan. What post-processing software are you using for your AR guided procedures?
I so I would want to perhaps we should connect a little directly to answer that question. But I would want to say because I don't want to be in a position to actually advocate for certain vendors or the other.
Yeah,
But suffice it to say, there's actually multiple segmentation infrastructures within our institution, and they all work really well because they can all pull from DICOM images and they all can do their own 3D segmentation. They all can actually export to a certain type of file extension, the OBJ extension or an object extension that can actually be ingested by many of these AR. And frankly, that's also the extension you use for 3D printing. So not directly answering your question, but to say that this is something that you could do with any 3D lab. And really, every provider also has their what they're used to and what they enjoy interacting with.
perfect. Perfect answer. Okay, next question. How steep is the learning curve for proceduralists to become comfortable using AR visualization?
I think it depends on what aspect of the AR visualization you want to first, I guess dip your toes in, right? Then there's the AR visualization of how does this improve my ergonomics, um, where I have my ultrasound screen, my fluoroscopic screen. For me, that was a quick adoption. What was hard for me, honestly, was getting used to the fact that having a headset on because all of a sudden it changed the lighting that I needed in my room. And also some of these headsets are a little heavier. And certainly with technology, all these are changing, right? Now you have headsets that look like sunglasses. So as that evolves, I think a lot of these problems will disappear. I will say that when you start doing more fancier things like 3D segmentation with co-registration on anatomy, overcoming really the internal barrier of can I trust this technology was really what my barrier was, more so than actually interacting with it, because oftentimes you're fused with a modality you're comfortable with. In the cases I showed, I'm fused with ultrasound, so I always had the fail-safe of I'm very comfortable with ultrasound. I know this is the lesion. I'm going to add this to actually make me even more comfortable. And as you become more comfortable, all of a sudden you're starting to see where the use cases are.
Awesome. Okay. Next one. Let's see. Can you describe a specific case where AR significantly changed your approach or decision making during surgery?
Now, I think one of my earlier cases, I'm going to give two examples. One is perhaps getting to a target, and another example is really more on the research front as to how it can change treatment. I think one early example for me was I was doing a mediastinal mass biopsy. And often very close to the heart, very close to multiple vital structures. And certainly I'm always worried about where the internal mammaries are. And depending upon how high up you are, the internal mammaries are in different places. And so oftentimes when I'm doing these procedures, I'm being very careful. I'm using a very low depth probe. I'm marking out where the mammaries are. And so a immediate use case for me in one of these cases was, well, I can just do a 3D overlay with the contrast enhanced CT, tell me where the mammaries are, being very comfortable with it so that now I'm not so worried about it because I know exactly what I need to avoid. Now I'm more focused on getting to the target lesion, avoiding the lungs, which you can also actually overlay as well, overlay the heart, and really now almost focus on, all right, the heart is beating. I need to avoid that. I need to get to an area that looks very viable. And fact of the matter is, I also overlaid where I thought viable based on the PET. So all of a sudden, now you're curating information that you didn't have before. So I thought that to me, now it's hard for me to do a mediastinal mass biopsy, frankly, just under ultrasound, because all of a sudden I'm thinking, oh, there's so many added advantages to avoiding vital structures and looking for the viable areas. I want all this stuff for me. Then there's treatment. You can imagine that you can overlay a lot of information for yourself, right? Oftentimes, a lot of my other half of my practice outside of pediatrics is I'm an ablationist. I do a lot of thermal ablation for cancer. And one of the things I'm always trying to do is, well, how can I take my thermal maps, the manufacturer thermal maps, and in my head draw all these ellipsoids in 3 dimensions, try to figure out, well, did I cover the entire tumor? Did I avoid this vital structure? Is this large vessel going to actually have a significant heat sink effect? So all those things can actually be overlaid for you, right? So I think remarkably powerful.
Fantastic. All right, Jonathan has a follow-up question. On average, how much time do you think AR reduces in your procedure workflows?
Interesting question. So this is a very early. I would say that this is exciting to me because this is so early. I would say it actually currently adds some time for me, and this is unpublished data yet, but something that we submitted for publication where we actually did a little over 20 cases, and I try to answer that specifically, right? And I'm glad you asked that question because. That was the reason for that slide where I spent some time saying that's a barrier to adoption, right? Well, how does this change my workflow? um, long story short, on average, it added about 8 minutes of my time. And the 8 minutes of my time was a lot of that had to do with ensuring that the segmentation was correct, that I had all the curated information I needed. So you can imagine this actually then becoming a significantly lower once you become comfortable. I mean, it only took us 20 cases to get down to 8 minutes, right? But I need all my technologists to be comfortable. I need to be comfortable. And so now we're at the point where it probably doesn't add all that much time, but now it's starting to add value. I'm looking for certain cases where this could be useful. And so from a, part of my job is also administration, right? So I think perhaps what you're alluding to with that question is, well, is that allowing me to do an extra case to make the case to bring it into an institution? I don't think we're there yet, but we're close. However, you can make the case that all of a sudden you're doing cases that you otherwise would not have done, right? Or you're doing more complex cases that would have taken double the average amount of time, but you can do it in a, you've made a complex case a simple case. So I know that that's kind of a not a wonderful answer to be giving, but I think that that's kind of where we are, to be very, very frank. But that's why we all need to work together to get more evidence.
Awesome. I thought that was a great answer. All right, let's move down here to this one. Any patient population or anatomy type that you think could benefit from using AR more so than using the standard of care imaging visualization techniques or tools?
Great question. I don't know. But where I can surmise is you can imagine where if you had a lot of soft tissue and you couldn't penetrate very well with some traditional techniques like ultrasound, this could be very helpful in making you more comfortable, right? I think we've also all been there where we were trying to do a nephrostomy in someone with a lot of soft tissue. You think you see giant hydro, you're not sure, and you're tweaking your ultrasound to figure it out. Well, you can overlay this and say, well, you know what? I actually just slightly hypoechoic area that's gassed out or is grayed out is actually the collecting system. So now I'm much more comfortable in actually interacting. That said, I think that this is not a primary navigational modality yet, right? So I think that we have to think of this, currently at least, as an adjunctive modality to help further inform us. But ultimately, the provider has to make that decision. I say that very carefully, partially because, yes, I'm all about utilizing this, but I think that we have to understand where this technology is and where we need to go.
Fair enough, fair enough. Okay, we got time for a few more. If anyone else has anything they want to pop into the Q&A box or the chat, do let us know. Here's another one for you. You kind of alluded to it before with a paper that you had submitted, but is there any kind of clinical data or validation studies that exist for clinical use of AR?
Yes. So there is some validation data, and there is currently a lot of sort of first level data, right? First and second level data in the traditional sense of we've shown that utilization of AR with or without an adjunctive modality such as ultrasound can give you certain millimeter accuracy. And when I say certain millimeter accuracy, is usually within the 2 to 5 millimeter range. And that's generally also what the FDA kind of uses in general to say that this is accurate enough and safe to use. So that's been defined in some published animal work by various different vendors out there. Then there's the translating into, well, have we done the clinical trials to show its safety and efficacy? The safety has been done. In terms of efficacy, I think that's kind of where we are now, right? The efficacy and also the usability. Is this, and I think John was the one who asked this question, is this going to change my workflow? Is this going to impact my workflow? Does this actually help me? All those studies are currently being done now, both in a single center and multi-center setting. Then there's the high level data, where you start to say, well, does this now replace a current modality? Is this more superior? We're not there yet, but certainly I think within that 5-year window, we're probably going to get there.
Fantastic. So this is a little bit more of your personal use of AR, but what was your initial reaction when you first experienced clinical AR?
My initial reaction was, where have you been all my life? Because it's funny because we all probably take this for granted now, right? Your heads-up display in your car, or the fact that you have a GPS, and you can interact with your car with voice recognition to say, navigate me to this, or on the way, can you find me a Starbucks because I love a cup of coffee, right? Well, that started from somewhere. That started from, and I'm old enough to know that I used to be the one in that passenger seat with the maps opened up, trying to figure out where to go. And oh,
Mhm.
we just missed the stop. Now I got to re-triangulate and figure out what better place. Maybe we should stop at a gas station. Well, this is kind of where we are right now in AR, right? Where we see value, we see where we need to improve. We're now starting to see the initial iterations of what this could look like. And that's what makes this even more exciting. And that's why this was so exciting to me when I first saw it, to be able to actually be part of it and actually change the trajectory and really be part of exploring how we can utilize this, because this is clearly going to be something useful. We just don't really know how pervasive this could potentially be.
Awesome. All right, let's do one more. I think we have time for one more. This one came in from one of our listeners. What do you see as the next step and future-looking application of this technology?
Thinking multiple different places. I think certainly we could do a lot better in our co-registration, compensating for changes in your environment as you interact with the environment. A lot of the examples I gave were in interventional, where frankly nothing really moves, right? Because if you put a needle in, there's really minimal tissue interaction, minimal tissue changes. But you can imagine a world where you're utilizing something like this in laparoscopic surgery, where you're actually really moving organs out of the way. So I think that's the next level in co-registration. Then there's really the next level of interaction. I gave an example of interaction, calling in a friend, right? Your phone a friend. But how do you have multiple people with different display interfaces? Maybe somebody will be on their desktop, somebody on their laptop, somebody on their iPad, a few individuals with different types of headsets, right? Depending upon what you're comfortable with, interacting in the same environment and giving advice. Now that becomes powerful both for training and for real-time interprocedural use. So to me, that's my bias and my focus right now. I think those are the places that we can get at pretty quickly.
Fantastic. Well, thank you so much, Dr. Pua. That was wonderful. We're really grateful for you sharing your expertise and your experiences using this amazing technology. We really appreciate you being here.
Great. Yeah, really happy to be here, and thank you for the invitation. And I'm excited, and hopefully, we all as a community can really roll up our sleeves and get to working with this. So thank you again.
Absolutely. I also want to thank MediView for the collaboration on this webinar. We appreciate their support of Radiology Today magazine, as well as all the professionals who share their mission of advancing human health. I do want to mention that MediView's AR technology will be at RSNA next month, so be sure to stop by their booth. It's number 6637 to experience this really amazing and really cool tech. And with that, thanks again, Dr. Pua. Thanks everyone for joining us. We've come to the end of the presentation. I wish you a happy rest of your day and a happy rest of your week.